Okay, good afternoon. Why don't we go ahead and get started? This is Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine at UCSF, and we are thrilled today to have Annie Luetkemeyer speak. Annie is Professor of Medicine based in the Division of HIV, Infectious Diseases and Global Medicine at Zuckerberg San Francisco General. Annie went to college at Stanford, I think majored in American history or something like that. Went to Harvard Medical School, and we were lucky enough to have her come out here for residency, fellowship, some advanced training in clinical research, and she's been on our faculty through her entire illustrious career. And the career is one in which she has really emerged as a national and international leader, particularly in clinical trials around infectious diseases, with a particular focus on HIV. And her topic today is HIV in 2025, what's new and what is next. We will not talk about the politics in general, although it may come up in the question and answer. Annie, welcome.
Thanks so much for having me. Bob was kind and gave me maybe the biggest topic ever of covering all the new and exciting things in HIV. But it's a great opportunity to zoom out and talk about some exciting changes and what we see on the horizon. These are my disclosures, and they are all research grant support to UCSF. So my roadmap today is taking on that bit of a daunting task to cover. I'm going to give you a snapshot of current HIV epidemiology, and then talk about what's happening now and what's next in HIV treatment, prevention, HIV cure. And then we're going to take a little bit of a detour to talk about another sexually transmitted infection or group of infections that are also important and really have been a syndemic with HIV in terms of their impact on men who have sex with men. So we'll talk about bacterial sexually transmitted infections and some exciting changes and tools that we now have, including DoxyPEP. Okay, so let's start by the state of HIV in 2025. So UNAIDS released a 2004 report this past summer, which they do every 2 years, and really gives you a big view of what's going on globally, and it's a chance to hold ourselves all accountable. So we know about 40 million people are living with HIV globally. And in 2023, which is the last year that was included in this report, there are about 1.3 million new HIV infections and about 630,000 deaths due to HIV. But let's try and put these numbers in context and think about what they mean and what our progress is. And as with many things, we've made tremendous progress, but this is a glass half full, glass half empty situation. So I want to break it down into these three buckets. First of all, treatment. Treatment is in the blue bars that you see here. You can see that there's been tremendous improvement in the rollout of antiretroviral uptake. And importantly, this has been integrase-based now in recent years, and we'll talk about what this means, but really well tolerated, highly effective medications. So the good news is that we have more than 30 million people taking antiretroviral therapy, but that's only 75%. Now, when I started out in this field, this would have been an enormous success, and it is an enormous success, but it does mean that 9 million people, or 25%, are living without access to ART, and we know we can do better than that, and we're not on track to meeting our goals there. So we can certainly do better in treatment. What about deaths? Deaths is represented in this red bar, the red curve here. And importantly, deaths due to HIV or AIDS-related causes have really come down. And that's incredibly important. But a person dies of an HIV-related cause every minute around the globe. And that's just too many people dying from HIV and deaths that really are, by and large, preventable. So not only can we do better, and we should do better, but we know that we're not on track for the 2025 targets. We're substantially above where we want to be, and that's located in that little red dot in the lower right-hand corner. Then lastly, prevention. How are we doing? Well, I think some great news. We've seen steep reductions in new infections in places like sub-Saharan Africa, which are very hard hit, so more than a 50% reduction. But we still have 1.3 million people, as I mentioned, who acquired HIV in 2023. And that's more than 3 times the target that we had set for ourselves. And we know we have highly effective tools that work to prevent HIV. So this is, as the report was titled, The Urgency of Now. We have really tremendous tools that we didn't have, and it's on us to keep the political will and incentive up to achieve these important goals. So let's then zoom to the United States, come back from the world view and look in the US. Well, in 2022, we had an estimated 1.2 million people who were living with HIV. And importantly, our numbers of new infections really have not moved in the way that we wanted to. We have 31,000 estimated new HIV infections. Let's talk about who these are and what we had hoped to achieve. So about 2/3 are among men who have sex with men. About a little less than a quarter are among folks with heterosexual contact, and about 7% were those with injection drug use. And again, our target had been much above this, and we really only have a 20% decrease from 2012. So in a decade, we're still seeing really an enormous number of new infections. And what I would say in the United States is an entirely preventable disease. If we treat people, they won't transmit, and we know that we have very, very effective tools for people to take to help keep themselves safe. So some work to be done on this front, especially. I want to point out that disparities in new HIV diagnoses in the United States also persist both geographically and in terms of race and ethnicity. So we know that nearly half of the new infections in 2022 occurred in the South, which has really borne the brunt of new infections, and some work to be done there. And then when we turn our attention to race and ethnicity, the group that is the most impacted are Black and African Americans at 38%. Black MSM, men who have sex with men, have the highest diagnosis rate per 100,000 population, and that's been stable. And stable is not a good thing in this situation. And we know that Black women have the highest number of diagnoses among heterosexuals, and this has also been stable. And so this is an area where we can do better. Following on the heels of this population are Hispanic and Latino folks who make up about 1/3 of new infections. And Latino MSM, men who have sex with men, have the largest absolute number of new diagnoses, and distressingly, this has increased by 20% over the last 4 years. So this is also a group that really is suffering disproportionately the impacts of new HIV infections, and really deserves our attention for our prevention efforts. So how about in our own backyard? I'm giving this talk in San Francisco, although I know people may be joining from outside here. We have a little over 15,000 people who are living with HIV in San Francisco. Our population looks a little bit different. About 90% are cisgender men, and 75% have been infected through MSM transmission, so sexual contact between men. We also see racial and ethnic disparities with disproportionate HIV infection in African American and Hispanic populations, and something that we're trying very hard to work to address. So how about the other key pieces here? What about deaths? So deaths are indicated here in the red line. And you can see that starting in 2012, the deaths, we really see an inflection point, and deaths started to come down. This is in part due to really wonderful work by the Getting to Zero citywide coalition. This is run by Dr. Bookbinder and Dr. Havler, and they've really worked to bring together stakeholders from all around the city to say, what can we do to change the epidemic in San Francisco and truly get to zero? And I love that they chose to name it a very aspirational name. And you can see that we've really seen new HIV diagnoses. I'm sorry if I misspoke. That's in red, not deaths. Really come down, and that's incredibly important and heartening. Although if you see in the last couple of, do I have a pointer? And just the mouse. Not sure. Oh, there we go. There we go. You can see in the last couple of years that this is flattened out. So we still have work to do in order to truly get to zero. When we talk about deaths, that's in the yellow line, and this has been flat. And then maybe with an uptick over the past couple of years. Now, importantly, 80% of deaths in 2022 in people living with HIV were due to non-HIV related causes. And this doesn't come as a surprise. I think we all know there's been a lot of overdose deaths and a lot of other comorbidities affecting this population, but these are not HIV related deaths, nonetheless, something that we're working hard to help extend the healthy life expectancy of people living with HIV in San Francisco. Well, what about HIV viral suppression? And we're going to talk about how we treat folks, but our number one goal when we're treating people for HIV is to get their viral load suppressed, because we know that stops disease progression and is associated with better outcomes. So the US national viral suppression in 2022 was 65%. And I want to point out that that's below global viral suppression rates of about 73%. And certainly we know that some sub-Saharan African countries have far exceeded this, meeting the 95 goals here. So work to do in the US. San Francisco's done a little bit better at 72%, but I think some really exciting data came out this year from the Ryan White clinics, and these are federally funded clinics that provide resources for low-income patients to help them get the care that they need, and it provides HIV care for more than 500,000 people living with HIV around the United States. And as you would imagine, these are folks who, low income and may have a lot of things going on in their lives, and yet they reported this year that they have a 90% virologic suppression. So that's really tremendous and shows what can be done when the needed supportive services are provided. And where I practice at San Francisco General is a Ryan White funded clinic, and we also have similar suppression rates of about 90%. And this is a picture of the entrance going into our clinic, which was formerly where the Department of Public Health was, but now is our clinic. So I think this is a bright light showing what we can do, and that we need to learn from programs like Ryan White about what we can do to get US viral suppression rates up. So in summary, what's the state of HIV epidemiology in 2025? Well, I would say that the bad news is that we are not on track to end AIDS as a public health threat by 2030, globally or in the United States, despite, I think, some really impressive advances that show that we can get things done when we have the political will to do so. We have made progress towards universal treatment, but substantial gaps still do remain. We've had inadequate scale-up of highly effective prevention tools, and I'll talk about some of those in a bit. And unfortunately, the inequalities that drive the pandemic, we're seeing both locally and globally, are going to have to be addressed for us to help close these additional gaps. But I think there is a lot of attention to these disparities, and I'm hopeful that will allow us to address them. Okay. I'm going to move on to advances in HIV treatment. I'm an HIV provider and clinical trialist, and this is the part that I find really fun and exciting. So I'm looking forward to sharing this with you. So how do we think about HIV treatment in 2025? Well, right now, our guiding principles are that treatment should be immediate in most cases. There's a few exceptions when people have some kinds of opportunistic infections, but really you should be asking, why is this person not be treated? Our principle is that everyone should be treated immediately, universally, and for now, lifelong. We're very hopeful that we'll have interventions that will allow people to come off of ART while remaining suppressed or in remission, but we don't have those yet. I would also add that the expectation is that these medications are very tolerable. If we're going to give people lifelong treatment, the expectation is that they're able to, take a pill a day and do very well and not have it impact their life in the way that medications used to in what we think of the bad old days of life-saving but hard to tolerate antiretroviral therapy. So when I'm talking to someone in clinic and they're newly starting HIV medications, which can be a pretty, challenging and pivotal time in someone's life, especially if they're bringing in a lot of baggage about what this might be like, I try to share with them really three things. That if you have an uninterrupted access to ART, not only can we expect that you should be able to take a medicine that doesn't affect how you look, that you can tolerate well, a lot like a blood pressure medicine or treatment for diabetes, you take it and then you don't have to think about it. But you should expect with taking these medicines that you have a long, healthy life. You're going to have to worry about the boring stuff that the rest of us do, getting colonoscopies and getting your teeth cleaned. Expect to have a long, healthy life. That is what we see when people take antiretroviral therapy. They should expect to be able to have children however they choose to procreate without passing on HIV to them. And really importantly, that they can expect to have sexual partnerships without transmitting HIV as long as their viral load remains undetectable. So this is what's called undetectable equals untransmissible, or U equals U. And I want to say that this is in the absence of using condoms. And I think this really is a game changer for a lot of folks, particularly if they're in a discordant relationship that's long-term, has allowed them to have the anxiety about transmitting HIV to others really come down. And if they're not in a long-term monogamous relationship, also to reduce that anxiety, because as I will often say to people, sex is a part of life, and our goal is to have you be able to have this be part of your life in a way that feels safe and not anxiety provoking to you. So the current HIV treatment landscape, I would say by and large, is focused on the integrase inhibitors. I can't give a talk without showing the life cycle. So here on the right-hand side, you can see where the integrase inhibitors act, and they work to prevent HIV from integrating while they're in the nucleus, which is a critical part of the HIV replication life cycle. And these medications typically are simple, provided as simple once daily fixed dose regimens of 2 to 3 drugs. And I'm showing you 3 of the pills at the bottom of the screen that are recommended through the DHHS guidelines. The first 2 are 3 drugs that are combined, and the one on the right is only 2 drugs, and that's okay. In the right setting, it's okay to give people 2 drugs. So the dogma that it has to be 3 drugs, really, the triple cocktail really is no longer the case. And I'm going to share with you a number of other examples where we very effectively combine 2 drugs together, and it works quite well. These are highly effective, in general, well tolerated, and have very limited drug-drug interactions. So as I mentioned, sort of the bad old days of all the drug interactions from protease inhibitors, while we still use those in a minority of patients who need this, really is not the case, and we don't see a lot of the dreaded body changes that we did in the old days. They have a high barrier to resistance, which is a good thing, which means that people, if they're taking them correctly, can take these medications for decades. Patients often ask me, well, isn't this going to run out? I've taken this medicine for 5 years and it's really great, but is it going to stop working for me? And with these medicines, we have no reason to believe that that will be the case, again, as long as people take them regularly and haven't developed drug resistance. I also want to point out that for the 3 drug combinations that I show here, they contain a formulation of tenofovir, so this also treats hepatitis B. And this is important to know for 2 reasons. We have about 300 million people globally, depending on what estimates you look at, living with hepatitis B, and about 10% are going to be HIV co-infected. So it's great to get dual bang for your buck when you're treating your HIV, but also really important to know that if you're treating someone for HIV, you're also treating them for hepatitis B, whether you know it or not. So hepatitis B, if you have to stop HIV medications, you may be inadvertently removing their therapy for hepatitis B. So please keep that in mind. I did digress into viral hepatitis, but I couldn't help myself. Okay, so what do we need then? Are we done? Is HIV drug development over? We have a pill that I just told you was terrific. Well, these are great regimens. They're nearly perfect. They're not perfect. We know there are some concerns about weight gain that we're trying to figure out. And with a massive global rollout, we do see drug resistance that has developed. And people, we can see this on an individual level if adherence isn't ideal. But we also know that this really is not a one-size-fits-all situation. So suboptimal adherence to daily pills, unfortunately, even though these are well tolerated, is common. Humans are humans, and it can lead to resistance. Some people just can't take a daily pill regularly for a whole variety of reasons. And for them, long-acting injectables can be truly life-saving. I'm going to share some data about that with you today. And some people really just prefer long-acting options for both HIV treatment and for other medications for a whole variety of reasons. It may be more convenient to them just to come into the clinic and get a shot once every month or once every 2 months. The stigma around HIV medications, I can't overstate this. Some people really don't want someone to find their HIV medicines. That comes with a lot of stigma. And I've also had patients tell me that even if they take 10 pills a day, it's that HIV pill that reminds them every day of living with HIV. And for some people, that's really unbearable, and they don't want to be reminded of that. So they'll take the 9 pills, but that 10th pill really, really does a number on them. And I want to really respect that and the stigma that is carried with this. And some people just have a preference for the route. They don't want to take a pill. They prefer a shot, a patch for the delivery of their medications. And I want to point out just one kind of interesting fact that we're not going to get into a lot here, but when you receive injectable medications, you have a decreased risk for drug interactions because the drug concentration is dependent on the release rate rather than on renal or hepatic clearance. So sometimes you can get away with giving medications that might have drug interactions that don't have the same drug interactions when it's given through an IM or subcutaneous route. So sometimes there's a benefit if people are on other real perpetrators of drug interactions. But maybe most importantly, because I grew up in the 80s, I learned from a very important ad campaign that people want to have it their way, okay? And as human beings, we just like to have choice. Choice is good. And honoring that, and we've learned this through the field of contraception, that, you know, birth control pills were really revolutionary, but they're not going to work for everybody. Some people would love an IUD or want an implant on implant. And by having choices, you really increase people's satisfaction with what they're using, and their ability to continue to take these medications in a long-term way. Okay, so what do we have now that is beyond just taking one pill once a day, which is wonderful for a lot of people? Well, about 3 years ago, just around this time, January 2021, the FDA approved the first extended release injectable drug regimen for adults living with HIV. This is a combination of two different drug classes, and that's okay. Two is okay, it works well, of an integrase inhibitor, so in this case, cabotegravir, and what's called an NNRTI, and in this case, this is called rilpivirine. And it's given as 2 intramuscular injections, typically in the buttocks, so gluteally, every 1 to 2 months, and more often programmatically, we opt for every 2 months. And really just in the trials, these medications worked incredibly well, and they were non-inferior to oral ART in this hand-selected population of registrational clinical trials of virally suppressed patients. So that's, you know, folks who already were doing well on oral ART and got randomized to stay on it or switch. And these were folks who obviously were interested and willing to take an injectable. We did find that not only did they work very well, but people who chose to be in these studies were very happy with receiving injectables and often chose to continue this in this self-selected population. As you may expect, injection site reactions and nodules with an IM medication are the main side effects. They tend to go away over time, but it is something that I try to counsel people about, to be aware of this, and that they can expect to have some discomfort with the injection, and from time to time, these nodules that may persist. Unfortunately, and I think one of the Achilles heels here is that failures can occur even with on-time dosing. And when they do occur, they can lead to resistance to one or both of these drug classes. So they're not perfect, but it certainly has led the way for, in general, a very highly effective option here. So I've mentioned that this is in a group of folks who were already virologically suppressed and were, in sort of a selected clinical trial population. But what about one of the areas I think that is most important for these new injectable agents is people who have trouble with adherence who can't take oral pills. How does this work in people who have adherence challenges? And I want to share 2 pieces of data that I think are really exciting and have expanded the use of these agents. So first of all, on the left-hand side, the ACTG conducted a study that was called the Latitude study and looked at people who'd historically had trouble taking antiretroviral therapy. And they were randomized to either continue oral therapy or get injectable therapy with cabotegravir and rilpivirine. Now, in this study, for safety, they wanted to get people virologically suppressed first. They used economic incentives. They paid people to get suppressed. But once they were suppressed, then they either stayed on oral therapy or switched to injectables. And it was open label. They knew what they received. And they saw less virologic failure and less treatment discontinuation with long-acting antiretroviral therapy. So this I think, was a really important proof of concept that people who had adherence challenges did very well with long-acting ART, and they did better than those on oral ART, and the study was actually stopped early. Now, many people who are adherence challenged have HIV viremia, though, and they aren't able to get suppressed because they aren't able to regularly take oral therapy. So where I work at San Francisco General in our HIV clinic, which we call Ward 86, they've generated some of the most detailed and comprehensive data on long-acting ART use in viremic patients. And I'm referring to published data here that comes from Monica Gandhi and Kat Christopoulos, and this paper was led by Matt Hickey. So looking at 59 people who started cabotegravir rilpivirine with viremia, 80% suppressed on Cabril, which is tremendous. They all started out viremic. 92% suppressed on any regimen. Some folks switched. They didn't like the injectables and switched and were able to then be suppressed on oral therapy. But as is not unexpected, in those who failed, some did develop drug resistance, which is unfortunate. We've put many more folks on, starting while viremic. And so we have a growing body of data that Dr. Spinelli, Gandhi, and Hickey will be presenting later this year. So based, though, on these data from both the Latitude study and the great, really groundbreaking data that's been provided through Ward 86, this has been a practice changer. So not only is cabotegravir rilpivirine, FDA approved as an option for people, but the guidelines, the DHHS guidelines said, this should be an option for viremic patients with adherence challenges who just can't take oral ART, because this may be life-saving for them. And again, they're going to need supports to make sure they can come in and get on-time injections and recognize that the adherence challenges they have may present challenges. So make sure you have the programmatic infrastructure there. But having this as an option, I think, is an enormous step forward for some of the most vulnerable populations that we have. Okay. Well, what about outside of the United States in resource-limited settings? This is clearly a great tool, but would this work in a more of a public health approach? So the CARES study was published this year in Lancet ID, and it was led by Dr. Sissy Kitio and others. It was conducted in Kenya, Uganda, and South Africa, and they randomized people living with HIV who were already suppressed on oral ART according to whatever their local standard of care was, to either continue oral ART or to switch to injectable cabotegravir rilpivirine. They had very limited HIV monitoring. They had no historical drug resistance testing available to them, and people might have failed in the past, but as long as they were suppressed now, then that was okay. Importantly, they couldn't have active hepatitis B because these agents don't treat hepatitis B, and this is even more prevalent outside of the United States. And what they found on the left-hand side, you can look at the green and the blue bars, which are almost identical, that injectable ART was non-inferior at 48 weeks to oral ART, which is just really exciting. 96-week data are forthcoming. It's important to have longer-term follow-up and understand what the durability is here. But I think, again, this is really was remarkable and really is a game changer. As expected, there were 2 failures on cabotegravir rilpivirine that came with drug resistance, which is unfortunate. And the small, I think there were 2 failures in the oral ART arm that did not have drug resistance. So this shows that the public health approach to cabotegravir rilpivirine can work in a resource-limited setting, but access is really critical. And right now it's quite problematic due to the inability to access one of these medications that's really hampering, the global rollout of cabotegravir rilpivirine as a treatment option, which really is where we should be given these exciting data. And we're very hopeful that movement can be made here, because I think this could be life-saving for a lot of folks if they choose or want to take injectables, and there's the programmatic infrastructure. Okay, so just a couple of considerations about cabotegravir rilpivirine as we think about where this fits in our armamentarium. So I've told you that there's durable, proven virologic suppression in those who are suppressed and switched to injectables, but there's really great quality of life data that I'm not going to show you, where people have said, and I've certainly heard this in clinic, boy, this was a game changer for me because I no longer had to take a pill. I felt so much better about myself. The stigma went away. I really liked this. Some people don't want to take an injectable, and for them, and if they're delighted with the pill, that's great. But it's just good to know that for folks who choose an injectable, that they have seen real quality of life benefits here, and can be life-saving for those who have been unsuccessfully able to take oral ART. As I mentioned, it's 2 IM injections every 2 months. This is a big difference than sending someone to the pharmacy to go pick up their regular medicines. This means that your clinic has to come up with the infrastructure to buy the medication, to give the medication, to track down people when they don't show up. And none of that is paid for, by just writing for the medication. So there's been a lot of programmatic logistics at implementing and monitoring, and that I think have hampered, again, large-scale rollout in the United States, but really requires some thoughtful planning about what this is going to look like. I've mentioned the risk of treatment failure, even with on-time injections. And in those folks who do have hepatitis B, this isn't going to be a choice for them alone. You can have people take injectables and then take a pill for their hepatitis B, which introduces a little more complexity, but that can be done. I mentioned the expense, and these are difficult to produce medications, so it hasn't been as easy just to roll out generics, which has led to, unfortunately, for now, very limited access in resource limited settings. And we would, of course, welcome more data for use in pregnancy. But nonetheless, a wonderful thing to have out there. What's on the horizon? Clearly, this is just the start of thinking about long-acting agents, which include injectable and non-injectable. So oral ART, longer-acting, many studies, including some that we're conducting now in my unit, looking at once-a-week combinations. Maybe that works for people. You take it on Sunday, just one time, and that works well for people. We've done that with medicines like alendronate, and for some that's worked quite well. Could we extend it beyond weekly? Could we get to monthly? If these work well, that might be a really terrific option because a lot of people don't want injections. Can we extend the window for injectables to even longer acting and move from every 2 months to every 4 months or potentially every 6 months? I think that would really reduce the programmatic burdens as well as the burdens on people coming into clinic. What about combining injectable ART with what we call BNAbs, broadly neutralizing antibodies? And there have been a number of studies looking at this. This might be a novel combination and opportunities in particular to extend the interval, dosing people every 6 months or longer. And then we've certainly learned from the contraception world that implants are attractive to some and a lot of interest in developing, long-eluting drug compounds that can be used with the well-established implant platform. So stay tuned. I think maybe Bob will have me back and we can talk about what the horizon really has panned out for. These won't all come to fruition, but I think that the field of HIV drug development is quite exciting right now. So HIV prevention. I want to shift gears and then talk about where we are, what tools we have in the HIV prevention toolbox, and what might be on the horizon and changing our access to HIV prevention, because clearly we have some work to do. So here's the work that we have to do. This is again from the 2024 UNAIDS report. So in blue, I'm showing you globally the number of people who've received PrEP at least once. This doesn't mean that they're still on it, but they've received PrEP at least once. And at the bottom, you can see the geographic regions around the world. And then in red, this is the 2025 target for where we wanted to be in order to be on track to ending the HIV epidemic. And what you can see is that there's a pretty big gap in all of these blue bars not reaching the red dots. I'll say that Eastern and Southern Africa, I can get this to advance. Eastern and Southern Africa probably have the least gap, although they do have a gap and have done an admirable job of rolling out PrEP. But the far right, which is Western, Central Europe and North America, has an enormous gap, including in the United States, where we think about 1.2 million people may benefit from PrEP, but only 36% are taking it. So clearly a lot of work for us to do here, and hopefully new tools will help. Okay, so let's take a step back and then ask, well, I'm telling you that 1.2 million people in the United States could be offered PrEP. Who are we talking about here? Because this has really changed over time, and I think maybe really relevant to the audience here, which I know isn't mostly HIV providers or PrEP providers. So starting out with what you would think, sexually active people who have anal or vaginal sex in the past 6 months, and any of the following: a partner with HIV, all right, got that, an STI in the past 6 months as a marker for risk of HIV, or inconsistent or no condom use. So sexual risk factors for HIV. We also know that HIV can be transmitted through injection drug use. So those who inject drugs and with someone who has HIV or who share equipment, this is a group that we should really be talking about PrEP in. I think in general, we've really kept PrEP siloed for many folks thinking about this. This is just about sex. It's not about injection drugs. And that's a really important group. But the last one is really a game changer. And I think we should keep this in front of mind. Anyone who asks for or asks about PrEP, we should have this conversation. I think we used to feel really nervous about PrEP and, boy, if people don't take it right, and then they're going to get infected. We have learned that we have great resources to give people PrEP. We have a lot of options. They work really well if people take it. We should be giving it to people. I think this is a similar hesitation that we've seen, in the early days of contraception. What if women take contraception wrong? What's going to happen? And what's going to happen if they can control their reproductive destiny? People want to do that, and people can and will take PrEP well. They need to know about it. If they're asking you about it, they're probably an appropriate PrEP candidate. So what do we have for PrEP? This is a little bit of a busy slide, but the bottom line here is that we have 2 different pills and we have an injection. And I've listed all the different populations. We don't have data to support use for all of these modalities for each of these populations, but we have something that will work for everyone, which is great news. And we're really continuing to expand our data. So just working our way through this, the first pill I have listed here is TDF-FTC or Truvada, and this can be taken daily, but also there's good data to support using on demand. So a pill taken before sex and then taken after sex. And for some people, if they're infrequently having sexual encounters, this may be what they might choose to use. There's another pill called TAF-FTC or Descovy that is also approved for daily use and may have less bone and renal impact. So that's been attractive. And again, both of these treat hepatitis B, so that's a consideration to keep in mind if you have folks who are living with hepatitis B and want to take PrEP. And then cabotegravir has been the new addition to the armamentarium. I mentioned cabotegravir, that's part of Cabril used for treatment, but there are really robust data out of the HPTN that show that cabotegravir can be used as an injection once every 2 months to prevent HIV very, very effectively in both men who have sex with men as well as cisgender women. All the barriers that exist to CAB rollout for treatment exist for PrEP in that, you have to have the programmatic infrastructure to do this. But I think it's been a very, very welcome addition to the armamentarium. And we're all hoping that programs are able to scale this up. I think the biggest game changer, however, as we look forward, has been lenacapavir. And lenacapavir got the Science 2024 Breakthrough of the Year, as shown here. This is an HIV capsid inhibitor, so a novel mechanism of action, and it acts at multiple different points in the HIV life cycle. And it's available as an oral formulation and a long-acting subcutaneous depot that lasts right now for 6 months. So that's a substantial improvement over the 2-month options that we have now. It's currently approved for salvage therapy in HIV. In other words, people who don't have other options and need to construct a regimen in the setting of drug resistance. It's not currently approved for HIV prevention, but is under review on the basis of 2 studies that I'm going to show you right now, which were really quite remarkable. So these were the Purpose 1 and Purpose 2 studies. On the left-hand side is the Purpose 1 study. This enrolled cisgender women and allowed pregnant and lactating women, which is really important. And often these are folks that aren't studied until later on in drug development. And they were enrolled from Uganda and South Africa. And then on the right-hand side is the Purpose 2 study, and this enrolled men who have sex with men, transgender men and women, and gender non-binary folks, really from all around the world, including in the United States, South America, South Africa, and in Thailand. The study design was very similar with a couple of little differences here. The women on the left-hand side in Purpose 1 were randomized to either receive an injection or one of the 2 oral formulations because we didn't have a lot of data for FTAF in women. And on the right, men were randomized only to lenacapavir or FTDF, which is Truvada. They did use, because it's not ethical to randomize people to not receive medication. So what they compared it to was basically looking at people who tested positive at the time of enrollment and used that to estimate what the background HIV risk was in the population. What you can see looking at Purpose 1, which is the women, is that there were 0 infections over 1 year, on average about 1 year of follow-up, which is really remarkable. This is what we are looking for. Unfortunately, the HIV infection rate in those who took oral preventative medicines was not very good. And when they dug into this, this was due to suboptimal adherence. And we know we've seen this in other studies as well as in the field, that adherence to oral PrEP in some populations has been suboptimal and led to HIV infections. In the men, we saw a very similar finding. Only 2 infections occurred in the lenacapavir group, which was substantially less than certainly the background rate, or to those who were taking FTDF or Truvada for HIV PrEP. On the basis of this, the studies were both stopped early, and we look forward to having these medications available when they are approved. So some things to think about for lenacapavir, the mechanism of action is that it forms a drug depot when it's injected subcutaneously. So people can feel often a nodule. 60% of people in one of the studies had subcutaneous nodules, and they didn't go away quickly because they're meant to be there for 6 months. So that's something for individuals to be aware of when they receive this. Injections can be painful, although we're learning more about how to try to mitigate that when people are giving more and more lenacapavir and getting comfortable with this. And then as with injectable cabotegravir, rilpivirine, access to people in countries with the highest HIV burden and populations most impacted will be critical. And this isn't to say that we need this in the United States as well, and some of those populations are really represented here, and I worry about cost being a barrier. So I'm hopeful that this will be an opportunity not only for these medications to be approved, but for us to really advocate for these to reach the folks who will benefit the most. What's on the horizon? Well, the company that makes lenacapavir is already talking about extending it to a once yearly injection, and programmatically that would be ideal. You can imagine just coming in once a year for your HIV prevention shot. If it's as effective as the every 6 months, wow, this would be really terrific to have. And you can imagine how helpful this would be, particularly in resource limited settings, but also in busy people who don't want to have to worry about HIV prevention and don't want to take a pill every day or around the time of sex. Cabotegravir is being evaluated as an every 4-month injection and potentially as an implant. And then there's a number of other medications for HIV prevention that are being examined. Monoclonal antibodies, once monthly pills, that might be a really attractive option for people who don't want injectables but don't want to take pills regularly. And then things like microarray patches, rectal douches, and inserts. So I think a lot of exciting work being done, and we hope that the landscape of HIV PrEP will continue to evolve and that our toolbox will become more robust. I want to just close the PrEP section by saying 2 things. I mentioned this with HIV treatment, but with HIV PrEP as well, choice really matters. And this was, I think, a study that so beautifully illustrated this that I wanted to share with you. This is from the Search Consortium, which is led by Dr. Habler, and she and Moses Kamya, Dr. Kamya, conducted a really nice study looking at dynamic choice. And this was conducted in Kenya and Uganda. And participants who did not have HIV were randomized to be offered the choice of PrEP or PEP, which included injectable cabotegravir along with support services. And they had the ability to switch. They could say, well, I'm going to start out with cabotegravir, but if I don't like it, I'm going to go to taking pills, or vice versa. And the comparator was just standard of care receiving PrEP through the local Ministry of Health clinics. And it's not surprising the overall HIV prevention coverage was higher with dynamic choice, when people were given a choice of what they wanted to go on and allowed to change their mind. So 70% of the time was covered versus 13% of the time being covered with standard of care. So, more than a 50% difference. And this stands to reason. We're all humans. We like having choices and we want to be able to change our mind, but really nice to see this demonstrated in such a large and meaningful way. And then importantly, did that work? Well, there were no HIV infections in the dynamic choice arm, and 7 occurred in the standard care arm. And these were published. Dr. Kamya was the lead author in Lancet HIV this year. So this is why we don't want to just rest on our laurels and just have oral PrEP, which works really well when people take it. Clearly, people have challenges taking it, but they also want other options. So just to close, adherence to oral PrEP is a barrier to efficacy still in some populations. Long-acting PrEP has the potential to be a game changer if people who need it and want it can get it. I think maybe most importantly, I want to close with PrEP needs to be more a part of our mainstream primary and sexual health care, similar to the way that we think about contraception and STI testing to ensure access. So I really want to make a plug to this audience that I know is not largely HIV and HIV PrEP providers, to say, how can this be part of your practice in bringing this up with people who maybe have a risk for HIV in their lives? And I know that PrEP often feels like this, oh, that's so confusing. You guys keep changing the rules. And how do I get up to speed with PrEP? So I wanted just to share, I think, 3 really nice resources that are available to really make PrEP for your patients, accessible both to you as the provider and to your patients. So the first is the NCC, the National Clinician Consultation Center, which is based at San Francisco General. And they have a PrEP warm line, so you can call and speak to a provider there. And they also have a quick PrEP guide with a lot of great information that is there. The NCCC also does HIV PEP, right? So they can tell you about needle sticks and post-exposure prophylaxis, viral hepatitis. So there's a lot of resources that they have there, but they've got a really terrific PrEP support services. San Francisco City Clinic, which is the municipal city clinic that does a lot of great sexual health, has wonderful handouts for both providers and for patients. So that's a terrific resource that I use a lot. And then colleagues at UW have developed an app for your phone, as well as a PrEP learning course that you can access, but having it on your phone certainly makes things very accessible. So just wanted to make a plug to you all to think about how you can incorporate PrEP counseling into your current practices, no matter what it is that you do, because I guarantee you take care of people who may benefit from having PrEP. Okay, HIV cure. So I am not an HIV cure researcher, and I'm going to share my perspective on HIV cure, but with a nod to Steve Deeks, who was very kind to share slides and his perspective. So first of all, people have been cured of HIV. There are 7 people who've been cured with allogeneic stem cell transplant over the years that we know of, which clearly is not going to be a scalable intervention. These are folks who had cancer and needed a stem cell transplant for other reasons, but did lead to a cure, often in the setting of getting a CCR5 delta mutant transplant, which made them not susceptible to HIV infection. Perhaps more of a larger pool are individuals who have developed sustained control of HIV in the absence of therapy, so not cured, but more of a remission. And we're learning more and more about this as we have more folks who've experienced this. First, there were the sort of long-term non-progressors, so folks who had virus but at a low level and took them a very long time to progress. Then we learned about a French cohort, the Vicanti cohort, where they stopped people on antiretroviral therapy. And while most rebounded, some did not and were able to naturally control their virus. They still had the virus, but they were able to control it. There are a small handful of people who look like they may have cured HIV themselves. And then probably the largest group is people who have been treated with a whole variety of interventions that I'm going to talk about. And after these interventions, look like they've been able to control their HIV. What we've learned from this huge body of data is that sustained control of HIV will likely require a low reservoir. So we need to do what we can to get that reservoir low, and then sustained host responses, both through their CD8 T cells and others. So this is a busy slide giving you a snapshot of all the things that are going on, but really to make the point that it's not going to be any one intervention at this point in time that's being explored. There's really 3 pillars: targeting the HIV reservoir, so getting that down, boosting the immune system so that it can control HIV when the ART is then removed, and then maybe giving the immune system a little additional help through cell and gene therapies, and a whole variety of different ways to combine these together to try to induce remission and possibly cure in these individuals. A really beautiful example of this was done by Steve Deeks, Michael Peluso, Rachel Rudischauer, Amelia Deichmann, among many others at San Francisco General. This is called affectionately the kitchen sink study. So 3 stages. They gave people vaccines and BNABs and reservoir reducing agents, and then stopped antiretroviral therapy and saw what happened. And again, what you see at the bottom is the kind of 3 different buckets that people landed in. 3 of them had a rebound. They were kind of right back where they started from. There were some folks who had a slow rebound, and then some folks who were stable at a low level, and then one person who sort of got the golden ticket with no rebound yet. The challenge here is figuring out, well, you want to know why that one person had no rebound and how long it's going to last. And we really have a lot to learn about how you would figure this out, and who's going to really benefit from these very intensive interventions. So my take home for this is that we know that HIV can be cured. There's a handful of examples, and that's really has sparked our scientific thinking about what can we learn from those cures that we can then scale and leverage to folks who aren't going to get a stem cell transplant. Post-treatment control can be achieved for some, but it's a minority. And how do we predict who will be able to benefit and do a better job of making that not a minority, but a majority? But the current approaches the experimental approaches are really intensive and expensive. And I don't think that anybody thinks that this is going to be what we're going to roll out to millions of people who are living with HIV. And even in those who do receive these interventions, when you attain remission, when you get the golden ticket, how long will it last for? So these are folks who are going to need to be monitored for possible rebound for a long time and maybe indefinitely. And that is anxiety producing when it could lead to, viral rebound with transmissibility and potential for disease progression. Given this, and given the scale of people living with HIV globally, I think there's an increasing focus on the idea of a one-shot cure. We're not going to be able to throw this intensive kitchen sink approach to people and scale this, even if we're better at predicting who it's going to work in. So could we use, targeted gene editing approaches like viral vectors or CAR T cells to come up with something that would be a one and done intervention? And a lot of exciting work, I think, ongoing there. So stay tuned. Okay. In the few moments that I have left, I want to shift gears to another, I think, really important epidemic, as I alluded to in the beginning, which is the epidemic of STIs, bacterial STIs, chlamydia, gonorrhea, and syphilis, which really have been syndemic with the HIV population and with folks at risk for HIV, including men who have sex with men. So just to set the stage of why this is an area of such concern, just want to give a snapshot of what STIs look like. So on the left-hand side, this is some data from the WHO, showing there are more than 370 million new curable STIs every year. Okay, gonorrhea, chlamydia, who cares? These aren't things that they're not like HIV, they're not life-threatening. It really can have a substantial impact on people. They can be uncomfortable. Chlamydia can impair people's fertility, can cause a very unpleasant strain of rectal disease that's called LGV. And obviously syphilis, when it occurs in congenitally, can be devastating for pregnancies. And some strains of syphilis can cause, syphilis can be associated with blindness and neurosyphilis. So it really can cause a tremendous amount of morbidity. The U.S. has certainly seen their fair share of STIs. We've seen a trend towards an increase in gonorrhea, stable, but a whole lot of chlamydia. And then I think what's on most of our minds is the rise in syphilis, which has been as high as it's been since the 1970s, and really distressing rates of congenital syphilis, which should be an entirely preventable disease. So this led to the recognition that business as usual just wasn't working. Counseling people, you need to use condoms, get tested, is not doing much to move the needle to prevent STIs. And we need other tools that are biomedical interventions that will be effective, in addition to condoms if people want to use those, but not relying on condom use alone. So that's where DoxyPEP came in. So what is DoxyPEP? This is the concept of using doxycycline, which is a commonly used tetracycline antibiotic that most of us in the audience are probably very familiar with. It's used for things like pneumonia. We can use it for skin and soft tissue infections, Lyme disease, all sorts of infections. When it's used as DoxyPEP, this is taking it as 200 milligrams after condomless sex, so oral, anal, or vaginal sex, as soon as possible. Usually the studies say within 1 to 3 days, but I would argue for really trying to take it as soon as possible as post-exposure prophylaxis, so PEP. And two recent studies, I think, really highlighted the efficacy of this as a biomedical prevention in men who have sex with men and transgender women. One study I led here in San Francisco, along with my co-PI, Connie Kellum at UW, and it was called the DoxyPEP study. And the second study was called the DoxyVac study, led by Jean-Michel Molina in France, also in men who have sex with men. And that was limited to those who weren't living with HIV. Our study included those with HIV. And what both of these studies found is that there really was a pretty remarkable decrease with the use of DoxyPEP in those who took it in chlamydia and syphilis by about 80% or more. It was a variable decline in gonorrhea, and we'll talk about the reasons for this, ranging from 30 to 50%. So gonorrhea did go down, but not nearly as much as chlamydia or syphilis. Generally, it was safe and well tolerated. And in our study, we saw efficacy regardless of HIV status. There were some concerns that it might perform differently in the HIV population for a variety of different factors. And that really did not pan out for us. I think the disappointing news is that these two studies and one previous study showed really good efficacy in men. The one study in cisgender women that was called the DPEP study that was run by Janelle Stewart and colleagues in Kenya did not show efficacy. But in the initial adherence data there, it looks like people did not take enough doxypep to cover their sex acts, and that may be the reason why. Thus far, my take on it is that there's not a biological reason why doxypep wouldn't work in women. And this may be similar to HIV PrEP, where the original studies showed a lack of efficacy in women, but it was likely due to them not taking it. And we know that now when women do take HIV PrEP orally, if they take it regularly, it works quite well. You just have to make sure that they're taking it regularly. So this led to CDC, final CDC guidelines that came out in June of this year to consider this, at least counsel all gay, bisexual, and men who have sex with men who've had an STI in the past year about this possibility, but that the evidence is insufficient for cisgender women, heterosexual men, and transgender men. I'll say that I do discuss this with folks who are cisgender women or heterosexual men if they have had STIs, and really try to do shared decision making for them while we're waiting for more data. Well, what happens if people take doxypep outside of a clinical trial, right? So here are these guidelines from the CDC saying that we should use this. And in San Francisco in October 2022, on the basis of our study, the Department of Public Health said, hey, this should be considered. So Maddie Sankaran, Stephanie Cohen, and others at the DPH did a really lovely study that just came out in JAMA Internal Medicine. And the bottom line was, this is an ecological study, so this is not randomized, but they just looked at what happened with STI rates. And I'm showing you a really long, this is over the past decade. You can see that rates have gone up. They hit COVID, they went down. It's not because people didn't get STIs. They probably just weren't, they might have had a little less sex, but they probably also weren't getting tested. But then they looked at this green line of when doxypep was rolled out, just said, what happened to rates in San Francisco? And they looked at rates in all MSM and transgender women, not just people who were taking doxypep because they didn't know. And the bottom line was that they saw that there was a reduction in chlamydia and syphilis by about 50% from what was predicted, but not a change in gonorrhea. And this tells you that when a portion of the population is taking doxypep, this suggests that there was an effect there. Well, gosh, maybe this would have happened anyway, right? We can't say that this was due to doxypep, but in a nice counterfactual, they looked at chlamydia rates in cisgender women who weren't receiving doxypep and didn't see a change there at all. So it certainly suggests that there's an effect. Similar data from Seattle show this, as well as from Northern California, which I think has been encouraging, and we need to learn more. So I'll close by saying this is an important new biomedical tool, reduces STIs in the individual and may reduce community level STIs. It's not working as well for gonorrhea, perhaps due to background rates of tetracycline resistance, which predated doxypep rollout. It's probably less effective in the pharynx and a smaller window of efficacy after sex. But we certainly need in the future better prevention tools for gonorrhea and need to understand how to use doxypep in different ways. I'll just close by saying that HIV has had a scientific impact well beyond the HIV field. I think a nice article came out in the UCSF magazine that I'll direct you to, talking about the different ways that HIV has moved the needle in other fields. So I will close there so we have time for questions. I really want to thank folks who contributed slides and their input.
Thank you, Annie. So a couple of minutes for questions. Why has drug resistance not emerged for the orals? I can't think of another infection where you can give the same agent for decades and resistance won't emerge.
Drug resistance to HIV occurs when HIV is replicating in the presence of the drug. So if you take the drug every day and it's working well and it's a highly effective drug, you don't get drug resistance, which is great. The problem occurs when you don't adequately suppress the virus, and then you have the ability to have replication in the presence of the drug.
Got it. For those that are interested in using the injectable, I think you implied that you still want full suppression if you can with orals. For how long, and how do you do that timing if I'm ultimately going to be on the injectable?
Yeah. So you can do what's called direct to inject. You can start people while they are viremic, but if they are suppressed, that's great, and we don't have a requirement for the amount of time. But if someone comes to you and says, "Hey, I've been taking this medicine for a while. I'm suppressed. I'm doing well," that's fine to switch. But I think we're more comfortable with cautiously providing direct to inject Cabrel for folks who are viremic.
Right. We have time for one or two. Anybody else?
Quick comment on the vaccine status, HIV vaccine, and also noticing that a lot of the deaths are due to non-HIV causes. Is that mostly cardiovascular or what other causes?
So status of vaccines and why are folks dying if it's mostly not from the HIV?
So still work being done to develop an HIV vaccine, but as you know, this has really eluded us thus far. I think a lot of focus on combination BNABs potentially as a way to provide a vaccinal effect, but despite a lot of ongoing hard work, we've not had an HIV vaccine that's been ready for prime time. Yes, overdose deaths, cardiovascular deaths. So important things for us to address that are not typically HIV related. Yeah.
If we're at time, we'll take one more. Al?
That was my question. I was wondering what the status was
Of the vaccine.
Yeah, he's been around for 40 years.
Yeah.
Yeah.
Yeah. You could also ask the question, what is the difference between an HIV? I mean, one and done would be ideal. But if you could give lenacapavir once a year, that's pretty darn good. So I think if we could have a vaccine that just worked and you could walk away and it worked as well as, the typical vaccines we think of, that would be terrific. But while we're waiting for that, I think this would be pretty darn good.
Success of these injectables people away from researching the vaccines much.
No, I mean, there's a whole HIV vaccines trial network, and I think a lot of ongoing robust work. So they're not giving up on that, and we hope that they'll be successful.
I think just last one, the lenacapavir was for PrEP. Is it work for treatment?
Yeah, so it's approved for treatment, and it's approved for salvage therapy, but they're looking at different combinations. Could you use this upfront? And the answer is yes. You'd want to pair it though with something that lasts. You want to have the same. It'd be good to have 2 6-monthers if you're going to use this. So I think that we'll learn more there. But people aren't using it for initial therapy right now, but that may change as we learn more.
Great. Eddie, thanks so much. That was great.